we will go ahead and get started. So thank you everyone for joining us for this month's Science Cafe. I want to just take a brief moment to introduce the CTSC for those of you who are not familiar. So our goal is to improve the health of people that live in Northern Ohio and beyond by providing resources and services to our hospital and university partners, clinical and translational researchers and scientists, as well as community members. The CTSC is currently doing this by focusing on these 5 key areas and initiatives, which are resources and services, workforce development, community engagement, health informatics, and then clinical and translational funding opportunities. So I want to take a moment to introduce both of our presenters for today. Dr. Ontaneda is a staff neurologist at Cleveland Clinic and a professor in the Department of Neurology for the Cleveland Clinic Lerner College of Medicine. Dr. Ontaneda has authored over 200 publications and is at the forefront of shifting how we approach MS care. He currently acts as the PI for the Deliver MS study, which is a landmark multi-center trial comparing early highly effective treatment strategies against traditional escalation approaches. And our other presenter is Dr. McGinley. She's a staff neurologist at Cleveland Clinic and an associate professor in the Department of Neurology for the Cleveland Clinic Lerner College of Medicine. Dr. McGinley is a leading expert in the integration of technology into clinical practice to improve patient outcomes and healthcare access. Her research focuses on digital health and the development of technology-enabled assessments, as well as the expansion of teleneurology models to reach underserved and rural populations. So today they will be discussing advancing MS research through pragmatic and multi-site clinical trials. So I will turn it over to both of you.
Great. Thanks, Mackenzie. So I think we wanted to start off with a couple of just polling questions so we sort of understood where the audience is kind of coming from. So Mackenzie, I don't know if you want to share those. The first one, as Mackenzie said, we're going to talk a lot about just our experience with clinical trials, specifically multi-site. And so the first one was, I feel comfortable with designing a clinical trial. Okay, great. So I think definitely just shows kind of a mix of people, which is kind of what we were thinking, is that there was kind of going to be an audience of people that obviously clinical trials are still new to them or they're working on, and then obviously some very experienced people on this. And then our next one, do you want to do the next one, Mackenzie?
I think the results were showing for all
Yes,
three.
all are launched together.
Oh, all of
So
them are out together. Oh, okay, perfect. I'm sorry.
yes, let's see if I share. You should be able to see now.
Oh, okay. You can see. Oh, okay, I see. And then I feel comfortable conducting a clinical trial, again, pretty similar to designing a strong mix. And then I have a support system to design a clinical trial. Again, seems like actually pretty good. So I think actually the audience is very well experienced with this. So with that, I think we can get into our presentation, which I don't know. I have it shared, Mackenzie, but it doesn't look like it's sharing for everyone yet.
I can see it.
You can see it? Okay.
We can see
Okay.
it. Mhm.
Perfect. Okay, great. So we'll get started. And these are our disclosures. And so this is how, well, I'm going to start us off and give a little bit of an overview. Both Dan and I work in the multiple sclerosis field, so we'll just give a little bit of background on the disease state. And then I was going to start off talking about pragmatic clinical trials and sort of the nuances to designing those and the lessons sort of we've both learned around that topic. And then Dan was going to talk specifically about large multi-center trials and again, the unique aspects of that and challenges. And then we'll definitely have lots of times for questions. And again, if there are trainees on the call too, we're happy to talk about sort of our transition from K awards to leading some of these clinical trials. So again, just a little bit of background for everyone about MS. It's an immune-mediated demyelinating disease of the central nervous system. So it is not the most common, and it's about 1 in 1,000. There are about 1 million people in the United States living with MS, and geographically it varies quite significantly worldwide. It is more common in women, although we again treat both sexes. And I think some of the interesting things about sort of the onset of MS is, unlike many other neurologic conditions, this does present maybe a little bit earlier in people's 20s, 30s, and 40s. And we take care of people really across the lifespan. So early on and then well into their 60s, 70s, 80s. So I think that is a unique and interesting thing about the population that we serve. Some terminology that we might both use is we typically think about MS in terms of different courses, although these are definitely being reevaluated. But you may think early on, we talk about patients being relapsing, remitting many times, where they have kind of these acute attacks of neurologic symptoms, such as, loss of vision over several days, numbness and tingling, weakness. And then over time, patients have less of these acute attacks and more just general progression. This really just depicts sort of the mixed biology that is MS. So we have this inflammatory component of the disease, and we also have a neurodegenerative portion. And so kind of leading up into the clinical trial that I'm going to discuss that I lead here is another big problem that we have in neurologic diseases in general is sort of access to care. And so as many on the call might know, is there's obviously an increasing number of individuals with neurologic diseases. So in 2011, it was nearly 100 million Americans that had at least one neurologic disease. And again, we have 1 million people living just with MS. So obviously there's a huge demand that's ever increasing. And that's coupled with a huge shortage of neurologists. So actually last year was projected to be nearly 20%. So a large mismatch. And then furthermore, as we know in medicine in general, there's a huge movement to subspecialty care. And so as a neurologist, most of our trainees end up choosing some sort of fellowship, which then means that centralizes them to typically urban academic type centers, and then also typically a smaller number of diseases they treat. Again, kind of centralizing care away from patients. And then many of our neurologic patients, including our MS patients, have physical and financial barriers to care that really limit their access. And so that really set the stage for a lot of the work that I do is the potential solution of teleneurology to help kind of bridge some of these access needs. So again, that sort of takes out those geographic barriers that patients have if they're just not near to healthcare facilities. Also, again, with some of the disability that our patients have, getting out of the home can be difficult. And so if they don't have to come to a healthcare facility, that helps. Greater access with more types of options. And then ultimately, there has been studies showing there's a reduced financial burden with the use of telehealth. So with that, we kind of said, well, what are the gaps of kind of integrating teleneurology into our MS care? And we said, well, yes, people use it even a little bit before the pandemic, but we don't really know as you do more teleneurology, how that affects their neurologic outcomes. We don't really know the impact on cost long term. We don't know kind of the optimal timing. Really what the preferences are long-term and the impact on health equity. And so although it's sort of an ad hoc use of telehealth, there was a lot of longitudinal questions, which I think is applicable when we think about chronic care in general. We don't have great long-term healthcare models that have been well tested. So this was the scientific basics for the question that I posed of like, how could we really study the use of longitudinal telehealth for multiple sclerosis care? And so when I was thinking about this question, we had to say, well, yes, we're going to want to do a randomized control trial comparing telehealth or in-person care, but what do we think about the trial design? And so that really led a lot of conversations around choosing a pragmatic clinical trial. And I'll talk about the details of the trial that we designed. So what is the value of considering a pragmatic trial? So one is that the idea is that you really incorporate it into clinical workflows. So when we think about a typical randomized controlled trial, you normally have visits that are outside of routine care. So patients have a burden of having their standard of care visits plus clinical trial visits. You tend to have very restrictive inclusion-exclusion criteria, which then, again, is helpful for studying scientific questions, but also can limit generalizability. Whereas in a pragmatic trial, you are a little more kind of trying to go for representative populations. From a data collection standpoint, again, for like a traditional trial, you have all of these standard CRFs. They're collected through clinical trial staff. You're kind of collecting completely separate data than what's in the medical record, whereas with pragmatic trials, we incorporate a lot of electronic health record real world data. From a monitoring standpoint, we again, from pragmatic trials, do more routine clinical care. And again, we are assessing effectiveness and safety with a pragmatic trial. So again, they are similar. We can answer a lot of questions, but there are some nuanced differences to these. So with that in mind, I wanted to kind of highlight and talk a little bit about sort of the challenges of designing pragmatic trials. So one is, how do you choose a study population that is still going to be informative scientifically, but also generalizable? The next is, how do you design a longitudinal study that aligns with standard of care? And then lastly, how do you choose outcomes for a study that are still scientifically valid, but decrease the burden on participants? So these were the main things I was thinking about when I was designing the virtual MS study with our team. So this is a 2-year, 2-site randomized clinical trial. And what is interesting is that we're comparing 2 years of virtual care to 2 years of in-person care for MS patients. And again, that was trying to answer those scientific questions of what happens when you do virtual care longitudinally and not just ad hoc. We really wanted to think about all aspects of MS care, which, yes, are predominantly a neurologist, but there are other things like rehabilitation services, where they get their infusion medications, their MRIs, all of these other comprehensive care aspects. And you can see here, the basic design was, patients come in for a baseline screening visit. They get randomized to either the telemedicine arm or the in-clinic arm. And then what we decided to do was then have no in-person visits other than the baseline visit and the 24-month visit. And so we'll get into kind of the complexities of that. So first of all, getting to that question of how we chose our study population. So again, we wanted it to be sound, but we wanted it to be, again, generalizable. So we did an age inclusion of adult patients, so we did not include pediatric patients, although MS is very rarely diagnosed under the age of 18, so that was a minimal kind of exclusion criteria. The next thing, and we had a lot of conversations around this, was the one kind of more homogenizing factor was patients who were newly diagnosed with MS in the last 2 years. The reason we chose this was because a lot of this is healthcare delivery, and we didn't want patients to have lots of preconceived notions of what care delivery should look like. And then we had some minor things around having a recent MRI, just again, kind of confirming the diagnosis, and that their neurologic provider was also participating in the study. But there were really not any other, we didn't have a end range. So in most MS trials, you'll see that people kind of have a 55 or maybe even 60 sort of age limit. We didn't choose to do that. Another thing you may have remembered that I talked about kind of different types of MS, whether it's progressive onset or relapsing remitting, it didn't matter. It was just a new diagnosis. So that was also something unique to the design. We didn't have any cut-ups of sort of their neurologic status. Another thing that can be a limitation in STEM study designs is still having people be ambulatory when they're admitted or entered into the study. We, again, didn't have any of those. So there were a lot of, I think, kind of things we did to make sure that this was generalizable, at least to a more recent diagnosis population. And again, we had pretty much no exclusionary criteria. We obviously wanted to make sure that people were able to give informed consent. And then if there was some other medical condition like very frequent infections or hospitalizations where we were concerned that it wouldn't be safe. But again, that is just a typical one. Otherwise, no major exclusionary criteria. And you can see a total population of 120, and we were going to enroll over 18 months. So that's how we sort of approach that, kind of trying to find a balance of an informative population, but still having it be generalizable. So the next was in study design. So, and again, I know Dan will talk a lot about this in his pragmatic trial, is that trying to decrease the burden on patients. So again, typical RCTs have patients coming in for standard of care visits and separate clinical trial visits. So for us, we had that baseline visit where they got randomized. That was a separate visit from their clinical visit. They were just identified at a clinical visit and we had them come in. So that was kind of an added burden. But then everything else at 6 months, 12 months, and 18 months, that was all conducted via phone calls or just electronic surveys with patients. So again, we didn't need them to come in for any research visits. We could do everything in their home. And again, it's because we chose a lot of outcomes that were patient-reported outcomes or economic outcomes that we could collect kind of remotely. And then the last was a 24-month visit that they did have to come in the office for. That visit, though, we did try to align with their standard of care visit so that many of those patients were coming in to see their typical provider, and then we're seeing our research team right after. And because of that, again, we were trying to lessen the number of visits and burden on patients. So then lastly, just talking a little bit about outcomes. So again, if you're decreasing the burden on patients and having to collect regular outcomes, you have to think about, well, what's feasible to get information from? So our primary outcome for this study is worsening in any of what's called the MSFC measures. So this is a timed 25-foot walk, a 9-hole peg test, symbol digits modality, or low contrast visual acuity. And so these are all tests that obviously you have to do in person. So we do them at baseline and 24 months. And then there are predefined worsening thresholds that we will be able to compare from baseline to 24 months. So again, that's something that we could do with just those 2 time points. And then for our secondary outcomes, we have a satisfaction outcome that again can be done completely remotely and we're capturing throughout the study. And then the second one is an economic outcome that is again completely remotely based on a health economics survey we're delivering every 3 months to patients via telephone. So that is, again, how we struck the balance of, yes, our primary outcome was an in-person assessment, but everything else, and plus we have many other exploratory outcomes, are things we could capture remotely for patients. And then the last thing I was going to say is that, as I've been talking is, and I think what we both wanted to kind of hammer in is that collaborations are crucial. So obviously I am a neurologist and my main co-PI for this study is also a neurologist, Dr. Beauvais at UCSF. That's the other site. We are very good at kind of thinking about the trial design and the actual neurologic care. I am not a health economics expert, and that's where it was great to work with Dr. Josh Carlson at the University of Washington, who I was introduced to through another neurologist, Dr. Jeffrey Cohen at the Cleveland Clinic, to help with that aspect of things. And then we also have several people on the other side of the graph, Dr. Deb Miller, Dr. Matt Plow, who's at Case, and Jennifer Pierce, who have helped with a lot of the kind of qualitative work and the patient-reported outcomes. So again, those are things that I have some knowledge of, but really am dependent on my experts to help with those aspects. And then we also have Dr. Misha Herbert here at Cleveland Clinic, who is an expert in implementation science. So again, this is a pragmatic trial where we're trying to change healthcare delivery. And so she has been very helpful in kind of showing what implementation outcomes we need to demonstrate to make this more generalizable. And then last, we of course have a wonderful statistician who helped us both with the design of the study and has helped with the ongoing, obviously, data analysis. So that has really been foundational. This is not a study I could have even remotely done by myself. And I think that's really important as you're designing these large trials, that you realize sort of what your strengths are and what you need in collaborators to really kind of round out your team. And with that, do you want me to stop sharing and you can start sharing? Hope you're muted.
Okay, you guys can see my slides.
I can't see them yet. No.
Let me try to share again then. All right. How about now?
Yep, yeah, we can hear. We can see them.
Okay. All right. Well, thanks so much for the invitation to talk today. And also thanks, Marisa, for kind of providing that introduction on multiple sclerosis and the experience with your trial. I think the audience probably knows that both Marisa and I were both KL2 scholars at different times, different generations of KL2 scholars, and I just want to reflect on how important the KL2 and specifically the CTSC has been for our career. And especially when you think about clinical trials, I think it is really something that helps you think about problems and conditions in a slightly wider scope. And that serves us really well when you're actually directing or in charge of clinical trials. And I'm going to talk to you guys a little bit about the Deliver MS trial. And so, the Deliver MS trial actually, I kind of owe it a little bit to the CTSC in a sense. I was a KL2 scholar, and we used to have KL2, and I think it was CTSC poster days. And I presented a poster on some work that I was doing that was completely unrelated to Deliver MS, but I got an award, and the award was, it was a $5,000 award to spend on whatever you wanted. And we were in the process of installing a 7T magnet here at the Mellon Center, which at the time was probably one of 10 7T scanners in the country. And I wanted some experience on 7T, and so it made sense for me to go to a place where they had done 7T for a really long time. And many of you probably know that Sir Peter Mansfield was one of the people that actually developed MRI technology, and he was at the University of Nottingham, and they'd had a 7T for at least 15 years before we got ours. So I thought it would be good, and I reached out to the person who did MS research there, who is Nikos Evangelo, and I spent, I think a total of like a week with him, and the idea was to learn about 7T MRI, but the reality is that what we talked about was that we needed a trial to figure out how to best treat MS patients. And the idea came up then, and then we kind of said, yeah, this would be a great study to do. We kind of said it, we kind of put together what a protocol would even look like, and Nikos went ahead and submitted that, I think, to the UK MS Society, but I really wasn't involved. And it wasn't until PCORI put an RFA out for large comparative effectiveness multi-center clinical trials that we came up with this idea. And the idea was to kind of investigate whether starting with the most powerful medications at the very beginning of your MS disease course would be beneficial as compared to escalation approaches, which means starting on the lower efficacy medication and going up in power as needed. And so there was a couple questions that we had to ask ourselves, before we even wrote the study, the grant application itself. And one of them was that these grant mechanisms, and that's like a common problem in clinical trials, whereas only a 5-year mechanism, which if you give yourself 6 months for startup, a year to enroll, 6 months to report out in the grant period, it leaves you with a relatively short on-study time. And this is the case, I think, for most NIH grants as well. The typical mechanisms are going to be mechanisms that just span 5 years. So you're kind of limited to the number of years that you can follow patients in these trials. And our overall design was, well, what we would love to do would be to take patients and, put them on one of these two approaches, using early highly effective approach or escalation. And our outcome would be, what do they look like at 10 or 15 years, right? That was kind of our ideal study design. Because we knew these medications in the short run would affect relapses and new MRI lesions quite well. But, what we don't know is if these medications have a long-term effect on disability. And if you're actually escalating people, do they actually do worse than if you were treating with an early highly effective treatment from the beginning? And that's where our first problem came. And in clinical trials, you have to become inventive about, coming up with solutions. And we said, well, maybe it makes sense to look at a surrogate endpoint that, can tell us if it's actually working or not. And one of the things that best predicts outcomes in terms of long-term disability is actually brain atrophy. So we had to do some work to convince the Patient-Centered Outcomes Research Institute, which is heavily based in outcomes that are related to the patient perspective directly, that brain atrophy was an outcome that was meaningful. But that's what we selected because we knew that we would be able to demonstrate that over time and within the budget constraints we had. So as an example here, Marisa talked about, picking the population and your outcomes. It was like really important. So for us, doing a trial that was powered based on atrophy required approximately 400 patients. versus a trial that focused on disability over those same 3 years, our power calculation came in at 2,600 patients. And recruiting a 2,600 patient study would be, I would say, virtually, impossible with the type of budget that they were assigning to us, which was it had to be under $12 million. So, these are the types of pragmatic decisions you make with clinical trials, and we knew we wanted it to be a pragmatic trial. And then we came to this discussion of whether we should design this study as a study that is a randomized control trial, or if it should be a study that was observational, because it's somewhat hard to randomize somebody to a treatment choice, right? And we know that these might have ramifications, and our MS patients typically come to us already informed about what medications many times they want to be on. And so it was funny, when the applications were going in for the Deliver MS study, we knew of other groups that were putting in, some of them put in just randomized control trials, some of them put in observational designs, and we were kind of debating if we would do an observational or randomized trial, and ultimately we decided to do both. And I spoke with a lot of people when designing this, and some of the people we spoke to were like, that's a mistake. It's like, you have to commit. Either you think you can answer it with a randomized trial, or you think you can answer it with an observational study, and pick the one you think is most likely. But our perspective on this was that, the randomized trial will inform a select group of people, but it won't really inform everybody. And ultimately, you want to know how people who don't opt for randomization do in clinical practice, right? Like, the reality is that clinical trials are always a somewhat artificial population, and we talk about efficacy versus effectiveness. And so, I think our idea of doing randomized and observational paid off. And for PCORI, we had to do a lot of work with, actually patients and stakeholders to demonstrate, one, that brain atrophy was a meaningful measure for them, and two, to demonstrate that there's a sizable proportion of individuals who would not be comfortable with randomization. So we did this study that, essentially has, two arms in it, if you like, or two cohorts. Patients were screened and they were randomized, and they could be randomized to escalation, early, highly effective. But there were people who were not comfortable with randomization, so they went into an observational cohort. And then we followed them over time, and of course, the most important thing for us in our study at this stage is brain volume loss. And so we're following individuals out to 36 months with MRIs every 6 months in the first year, and then yearly at month 24, and then at month 36. And the other thing that we really had to keep clear, that the intervention just had to be the initial DMT choice. And then after that, all DMT, disease-modifying choices for the patients, would be completely up to the patient. And I think that was important, because otherwise it was going to be really hard to have people participate. And our study had relatively broad inclusion criteria: people 18 to 16 years, established diagnosis of MS, that's pretty easy, relapse remitting, which is the most common form, recent disease activity, they had to be ambulatory without too much disability within 5 years of diagnosis, and be treatment naive, and eligible to receive at least one form of DMT within treatment arm. And we wanted them to have, EDSS 6.5 means that they're walking with bilateral assistance, so we required that they be using a cane or less, or using bilateral assistance or less. So, and we wanted to make sure that the study covered not just the US, but also the UK, and that was partly out of a design issue, but also because the reality of how treatment is given in the United States and the United Kingdom is quite different. And so we thought that the international aspect of this trial brought really a lot of depth to it. And so we had a total of 30 sites in the study, 15 in the United States and 15 in the United Kingdom. And it was a relatively large award. It was approximately $11 million, which I have to say now on the outset sounds like a lot of money, but we did this trial, if you compare it to what industry trials cost, like, it's kind of, cents on the dollar, basically. And a lot of this is, academic sites that are basically donating a lot of their time. That's kind of the reality of NIH and similar funding, that, these studies are really expensive to do, and, many times they're just done because you have a site principal investigator who's really interested. And so this is kind of what what very similar to what Marisa showed you for her study. It's, you really have to have a team approach for these things. And, I would say that, we had a steering committee, which is pretty common for a clinical trial. But we also had something that, we created based on kind of the presence of our stakeholders, which is an advisory committee. And that advisory committee actually is comprised of individuals with MS, caregivers of people with MS, stakeholders from foundations, National MS Society, the UK MS Society. We had individuals from payer organizations. So in the UK, we had an NHS representative on our advisory committee. In the United States, we had a couple advisors who were, basically people who were in insurance companies at high levels to help inform trial design. And we had two of these members of the advisory committee also participate on the steering committee. And I would say that that's something that I wasn't super familiar with because I hadn't done a PCORI study before, but having the input of these advisors in trials is like really important. And I think for anybody who's doing clinical trials, I think it's really, really important to have the presence of, stakeholders help you with study design. And then of course you have, all our 30 sites, half of them in the US, half in the UK, but then you have to think about the other stuff that's somewhat complicated. So a statistical site, so we had to divide our analysis in randomized data and observational data, and sometimes it's hard to find people that have the expertise at your own institution. So we had to go outside Cleveland Clinic, and we had to go outside the University of Nottingham to get that. So in terms of our statistical analysis for the trial, we have a statistician from the University of Oxford. And from the observational data side, with the resources we have in Cleveland, it was impossible not to have somebody like Tom Love and Doug Gunsler, who are the study statisticians for this, who are people who have a ton of experience with observational data. And then there's that big question of, CROs, and these typically are quite expensive. These are the companies that manage the databases required for running a trial, and Cleveland Clinic offers a service that can do that under C5, but it was actually too expensive for us to afford that, so we had to go to a small spin-off company called ImageIQ, which did MRI stuff, but they also created basically a clinical database for us. And I'll tell you a little bit about the changes that go forth with that in the challenges slides. And we of course had to have data analysis centralized, and so you have to have a group of individuals that are physicists that help with setting up the MRIs, because it's really important that those are equal across the site. So a lot of different resources and a lot of different skill sets that are needed. And I think this is kind of where the CTSC is helpful, because it helps you speak language with other people that allows this type of collaboration, and it's an openness and also kind of fluency in the language of multidisciplinary and transdisciplinary research that I don't think you always get unless you're involved in one of these types of these programs. So I just wanted to touch, similar to what Marisa did, was kind of a little bit on the challenges for multi-center studies. So I would say that I touched a little bit on this, but the pre-submission work is really important. There's preparatory work, preliminary data, but also setting up networks for clinical trials is really important, and many times those are underfunded. So you kind of are expected to set those up on your own, but they're expensive, right? You have to organize, something as simple as kind of at a meeting, setting up a room and, a breakfast, right? And if you're not funded yet, where do you get the funds for that? So I think having some pilot or funding sources from within your institution is super helpful for that. And then, I think your personal networking skills are really important. And that's why I always tell people it's really important in your career to, have good connections locally, but also have good connections in your field and participate in other multi-center studies, because that gives you visibility and lets you kind of enter these networks. In terms of kind of when you're actually putting in the submission, I think one of the things that was really hard was negotiation of costs. We were dealing with costs in the United States and costs in the United Kingdom, which were quite different. And those costs all have to be negotiated up front, and you need institutional approval from multiple sites. So you can imagine putting a grant in with when you need subrecipient forms from 30 sites takes an extreme amount of work and coordination. And so you really have to make sure you have the resources available for that. And when we started our study, which was in 2017, the whole idea of single IRB was something that was, people knew about it, but many large academic institutions did not want to rely on other institutions' IRBs, and Cleveland Clinic was an example of that. And actually, when we were setting up this, process for a single IRB, the IRB told me, no, you can't do it. We don't have the infrastructure right now to do that. Since then, now it is available, but it was one of those things that you just have to think about ahead of time. And then once you kind of post-approval, so say you put this all together and you get all your subrecipient forms in and your science is really good. And these are all kind of administrative challenges, not alone the science, making sure you have a good idea, but in the post-approval, then there's also kind of challenges, which is the contract and coordination. So, our study started in 2017, and initially this was around the time the UK was leaving the EU, and it was kind of, for us, it was a little bit hard because the UK, despite leaving the EU, actually did decide to retain GDPR as something that they did, and getting agreements with the UK sites that allowed for GDPR was really hard. And GDPR required a set of criteria both at the level of the institutions that were receiving the data, but also the other institutions that were participating. And so, for example, because we were operating under GDPR regulations, all our sites had to have their data protected in a way that was GDPR compliant, which involved having a chief information technology. And of course, none of the US sites, including Cleveland Clinic at that time, had a chief information technology officer. So it was one of these things that it was really hard conversations between legal teams about, can we be compliant with GDPR in writing, even though we're really not set up to do that, but it was a requirement. And dealing with foreign subawards is difficult. You negotiate a budget with, a transactional value between the dollar and the pound in our case, and by the time our agreement was set, it was completely different. And so, that gave us huge amount of headaches in terms of rebudgeting. And then another word kind of on indemnity, and this is something that's really, really big actually when you're doing clinical trials, is indemnity limits and language. And the Cleveland Clinic has a policy of unlimited indemnity, and I think European sites especially are quite unfamiliar with this, and they want to put a cap on indemnity. And we had a company that was going to do the randomization software for us, which was a UK company, and ultimately they told us, we cannot put an indemnity clause that has no cap in it. And Cleveland Clinic basically was saying, well, we don't know what they're going to do with the data, therefore we can't not have uncapped indemnity, which is, of course, a little bit difficult. And then, post-approval, then you think about stuff like site engagement, monitoring of sites, dealing with slow enrollment. So in our study, we had to deal with both the difficulties with the contracting of the setup, which related to kind of some slow enrollment, and then also COVID-19 hit during our trial. And so the UK, basically their research infrastructure shut down during COVID, and all those sites didn't recruit any patients for a long period of time. MRI, whenever you do trials that involve MRI, I think, it's sometimes nice when you just have clinical outcomes, because those are paper pencil many times or done by a neurologist, and those can be easily standardized across sites with some training. But with MRI, it's standardizing the machines, which sounds easy, but the reality is that these machines are constantly being updated and changed, and so you have to deal with that. Because MRI was our primary outcome, we had to deal with that. And then I think one of the big challenges we have is personnel change, and personnel change not just at Cleveland Clinic, for example, but also at the sites. And so we had some coordinators that were great and knew our study well and participated really strongly, and then they retired, especially after the pandemic. We saw a wave of very senior, seasoned coordinators who basically decided to leave. And then thinking about stuff like invoicing and tracking financials, which sometimes is a little bit hard. And then other issues that is not just multi-center stuff, but as we're doing more complicated trials in MS, specifically the complexity of cell-based studies, costs related to hospitalization and different medications that result as a complication of your experimental therapies has to be something you have to think about. Complexities associated with basket design, where you have a protocol that, as a single person that's signing on to the 1572, but you're responsible for research that is occurring, say, in your department, but also research that's occurring in other departments. And so that's a little bit hard. And I would say that in general, there's this increasing cost of database CROs and services that are compliant. With DeliverMS, we got lucky, so we hired this relatively small company, which was called ImageIQ, which was then taken over by a company called ERT, which was then taken over by a company called Clario, which has now been taken over by Thermo Fisher. So in the process of this study, we've changed hands, at least email addresses of database CROs 4 times, and we benefited because every time we got a larger partner, but our budget was already in the contract, so they didn't change our cost, so we got the benefit of kind of a big data CRO company with paying the price of a small startup. But I think if we were doing the study now, we certainly couldn't afford something like a Clario to be our database CRO. And then think about the expertise that you need for clinical trial conduct. So I'm a neurologist, and I can probably think about the questions and how to design the clinical trial, but you have to think about, for example, MR physicists, because they're the ones that are going to be making sure that the scanners are equally harmonized across the sites. You have to think about you need, for example, qualitative researchers. When you're conducting, PCORI has a requirement that you can conduct engagement through the course of the study, so you need people that have expertise in that. So it's hard, and I would say that in general there's decreasing financial viability for clinical trials, even for industry-sponsored trials, and so that puts pressure on us as kind of investigators, because what we do is less profitable. So I would say, kind of in conclusions of our study, so Deliver is fully enrolled. We enrolled a total of 806 patients into the study. We are going to read out the study in 2027, and we got a costed extension from PCORI actually to follow the patients out to 9 years. This was always the purpose of our study, and PCORI didn't have any mechanism to get that long-term extension. We got a long-term extension through the National Multiple Sclerosis Society, which co-funded our study. But we advocated to PCORI that we need this, that it's hard to be in the business of clinical trials and not want to do long-term extension studies, because a lot of the safety issues related to medications, and when you're thinking about comparative effectiveness, the equation is always efficacy against safety. Need long-term extension, and I really have to applaud PCORI, because they listened to us and they actually put an RFA out that was partially designed for our study for existing PCORI awards to follow patients out long-term. So kudos to them. The other thing I would say is that because there's so much pressure financially, I think once you get one of these large awards, the first thing you need to do is think about who else you can ask to help co-fund the study. And so we went to the National MS Society and the UK MS Society, and both of those organizations co-funded our study, because of course they wanted the visibility associated with a large grant like that, and they invested probably a couple $1 million each over the years, and so it was really helpful in making sure that the study gets done. And I think I would say, qualified research personnel is probably the most important thing when running clinical trials. You need people that you can trust. And there's a lot of regulatory red tape, and you need people who have experience with that. And those people tend to be a little bit more expensive, but are definitely worth the investment. So sorry, I went a little bit over, but I just wanted to thank everybody for their attention. And we were thinking that maybe in the last 15 minutes or so, we could do a little bit of question and answer and discussion.
Great. Well, thank you so much for all of that interesting um, information about your trials. If anyone would like to ask a question, they can either unmute or put their question in the chat. Not seeing, I saw Dr. McCumsey earlier had said, I think this was when you were um, talking about being previous case scholar. She said that we love to hear that and see your success.
So I can speak up. Oh,
Good.
hi everybody. This was really fabulous, incredible research, and I loved how you did give acknowledgement to the CTSA or the TCSC and all of the mentors and all of the connections you had. Just really amazing. I am very interested in pragmatic trials, and I've seen the Precis too. It's like a tool that you can use to kind of help you understand like where your study is pragmatic or maybe more explanatory. I just was wondering if you use that tool at all to kind of help you with when you were writing the grants at all, or if you were familiar with it.
Yeah, I mean, we definitely did. I think with Picori, in the initial round of applications, they didn't formally include it. In their second round of applications, they formally had a recommendation to include it, because of course they're doing, studies that are pragmatic comparative effectiveness studies is kind of their niche. So we're familiar with it. I think it's like one of those tools that you have to a lot of times when you're designing trials and when you're putting grants together, what you want to do is make sure you think about all possible angles. And I think tools like that help you do that. So definitely would recommend it. Not sure, Marissa, if you had any experience with that.
No, I was gonna say, yeah, interesting tool, but we didn't use it. The funding we have for virtual MS is through NIH, through the Nursing Institute, and so we didn't have any kind of guidance or kind of recommendation on specifically using it. I think I was, benefited from having Dan right next door who had just designed Deliver. And so in the field, we definitely stole some of those ideas, but I was able to use a clinical outcome and not an MRI outcome to make it also even a little bit easier on us pragmatically.
Thank you both. Really interesting stuff. Terrible disease, and so important to continue to find better treatments for your patients. I'm interested in the ethics of clinical research, and I suspect both of you have learned some things about any ethical challenges you faced, how you thought about them. So I want to sort of put that out there broadly. And then maybe more specifically, Dan, for your more traditional randomized clinical trial, thoughts about things you've learned from informed consent patients, considerations. You mentioned that some of the folks who are considering it weren't comfortable with randomization, but were okay being followed clinically. So contributing to generalizable knowledge in that way. So I'm eager to hear your thoughts about that. Thanks.
You can start if you want.
Why don't you go ahead and start, Marissa, and then I
Okay,
can
okay.
answer the second end of the question.
Yeah, no, I mean, I think so. Some of the ethical issues, a lot of times are around randomization, and making sure that you think there's one. I know Dan will talk a lot about this equipoise and both of the things that you are offering to patients and randomizing them to. So at least in our case with virtual, technically virtual care is standard of care and it's part of their routine clinical care. So that gave us equipoise. Obviously the nuances that typically it is kind of more ad hoc and it's not necessarily continuous. Now I think the fact that it was designed pragmatically helped us so that if a patient felt like they needed to be seen in person, or their provider also thought they needed to be seen in person, they were allowed to switch, and we just document that switching. So I think that ethical concern of if someone's having some sort of acute event and they need in-person evaluation, the trial absolutely would allow for that, and we would capture sort of the rationale around that and just had a whole system for understanding that. So I think that was, for us, one of the major ethical issues around kind of making sure people were getting safe and appropriate care. I think another issue we think about is sort of the representativeness of trials. And so to me, looking at our MS trials, they're not very representative when you look at phase 3 trials of what the actual MS population looks like. So I think that many of our pragmatic designs actually allow for better representative samples, which I think is really important when kind of understanding our treatment approaches in very diverse populations, where there's maybe minimal data in those populations and concerns that they do have different care delivery or different outcomes. So I think that is a concern in general about our CTs that I think both of our kind of pragmatic designs actually hopefully help a little bit with. But I would say those are kind of like the two main issues that we sort of tackled.
Yeah, so I mean, I was going to say that, kind of on the bioethics side of things, the main theme we dealt with was kind of this very hard randomization of, your treatment, right? And it was a little bit hard because on the one side, we're doing the study because we think that the treatment that you start off with really kind of creates a trajectory for what your, future disability is going to look like. And there's a fair amount of observational data that informs this, that suggests that high efficacy therapies are better, and there's a fair amount of clinical trials that show that high efficacy medications do better than low or moderate efficacy medications, but with the caveat that the randomized trials don't allow for escalation, right? Or they don't allow escalation like we would do it in clinical practice. So I think that sitting in the room with patients when we talked about these types of decisions, I think is hard, right? And you put your hat on it as a clinical trialist and you say, well, there's not sufficient data, for me to know definitively which option is the best. And so you can rationalize that out, and you can say, well, if you look at the United States as a whole, the majority of patients are treated with low or moderate efficacy medications, and if you look at the world as a whole, people are mostly treated with low or moderate efficacy medications. But as this study took 4 years to enroll, and the farther we got out, the more we learned that the more especially at MS centers, our sites were a combination of academic MS centers and community centers. But in the academic MS centers, there's this growing recognition that almost every patient should be treated with a high efficacy medication. And so you just had to have really transparent discussions with patients. And interestingly, we kind of did some work, preparatory work in focus groups prior to starting the study, and it was clear that people with MS really care about the decision being very clear cut, and the reality is that they were willing to participate, and the focus groups demonstrated that people were willing to participate because they knew that the results of the study would make the decision for a person in 5 years much more straightforward. And that's how I presented the study to the patients, which is, right now you could use either of these two medications. You can participate in the randomized trial, and I would tell people pretty transparently, we think that the high efficacy medications are probably going to be better, but there are some risks associated with them, and so that's why we're doing the trial. And if you want to participate, you can participate in both ways. And it was true that we did enroll the observational study quicker than we did the randomized, but it wasn't by much. It was like, I think, 8 or 9 months of difference. And one interesting thing that we thought would help us was, when the pandemic hit, there was a lot of data that showed that people on our most commonly used highly effective agents were actually getting serious COVID infections. And so we said, well, people started backing off clinically. Clinicians would say, oh, I'm not going to use a high efficacy medication because it's a little riskier. And we actually, did surveys to our patients when we asked people, if they want to participate in randomization, if they said no, we would ask them why they didn't want to participate. And what we found actually was that the likelihood to participate in a randomized trial actually increased post-pandemic. And it was almost like people wanted they were in a very uncertain environment, and adding uncertainty on a randomized design was hard. So they just wanted to, they just wanted to, they were okay with the fact that they could go in either direction. And so it was a fascinating kind of learning experience to go through that. And I think having the patient advisors was really helpful, because we were meeting with them every 3 months. And so these questions would constantly come up. And so having the patient's voice in the room when you're designing the trial and making these types of decisions is extremely helpful. And I think from an ethical standpoint, makes it better for you to actually come to the sites and say, listen, this is what our advisors are telling us. They could be somewhat biased, right? You can't take away that knowledge, but I think having that was definitely helpful. So I think you know I think getting the information on the people in the observational arm of the study is valuable, and I think it allows people to participate in research even if they're not willing to participate in randomization, which many times is not the case. So I think patients were also really thankful for that opportunity. And I know it looks like Doug is on, who's the study statistician from Deliver. So I'm not sure if Doug has anything to add about the observational arm and what it's teaching us.
Um, yeah, I mean, well, first, from a statistical perspective, this study is like very uniquely designed to have both just put together. So I don't think we're at a point with the full results yet. So we're on the um looking forward to that, actually getting in the weeds there.
Yeah, we've only been able to analyze baseline data,
Yep.
and it's interesting. I mean, we find in the baseline data that it turns out that UK participants were, the balance between using high efficacy or moderate low efficacy was much higher in the UK participants. And it seems like, that was probably driven by somewhat of a patient preference and somewhat of you know, a recognition that there probably is more equipoise, and it was more common practice in the UK to use low efficacy or moderate efficacy medications. And interestingly, we found stuff like education levels really determined whether a person would participate in a randomized control or not. Um, and it turns out that higher education was associated more with observational participation, which is a little bit counterintuitive. And so we're still kind of in the weeds of the analysis. And once we read out the entire study, of course, it will be even more interesting. But yeah, thanks,
Yeah,
Doug, for all your help.
it may raise a question about the quality of understanding of randomization in the less educated population,
That's
potentially.
correct. Yeah.
Thank you both for those answers. Really interesting.
Okay, so if anyone has any final questions, they can go ahead and ask them now while I'm pulling up this final slide. So I just wanted to show these two QR codes. So the one on the left is the registration for the upcoming session. So next month will be on real world data. That's on March 12th at noon. And then the QR code on the right is to become a member of the CTSC so that you can stay up to date with all of our upcoming events. And I don't think I see any other questions or hands raised. So we will go ahead and end the session. Thank you so much, Dr. McGinley and Dr. Ontaneda, for this great session.
Thank you for the invite.
Oh, thank you.
All right, have a good day, everyone.